panelists and participants of the Trauma Surgery Virtual Round 6. Welcome all on board as we will be starting the session relatively soon. I, Ashok Kannan, would be the chair for today's session, and I will be helped by the moderator, Mr. Izwan, who would be doing all the issues with the web, right? We would be talking on vascular trauma this time around. We have two distinguished vascular surgeons with us today. First and foremost would be Mr. Said Alwi, consultant vascular surgeon, who's based in Glen Nichols Medini Hospital, Johor Bahru, and Mr. Rosni Faizul, senior lecturer and consultant general and vascular surgeon based in Hospital University Science Malaysia. Together with both of them, we also have our two consultant trauma surgeons, Mr. Azuddin and Mr. Yuzaidi, to be part of the webinar session today. So in terms of our contents, we'll be talking of vascular injury, as I mentioned. First and foremost, we will start with a lower limb vascular injury case presentation by Miss Hafini from Hospital Tengku Ampuan Rahimah, followed by another presentation of an upper limb vascular injury from Miss Kalsom, based in Hospital Sultanah Aminah, Johor Bahru. And after both presentation, Miss Tiong Woon Yi would be taking us through an approach or overview of vascular trauma, and followed by a discussion and a Q&A session with all the panelists present today. Couple of housekeeping messages. First and foremost, I would like to ask each and everyone to unmute your mics in order to have a smooth presentation today. And if you have any burning questions, feel free to put in the chat group, or you can actually raise your hands later in the day to ask your question directly to the panelists and the moderators. All right, without further delay, I would now call upon Miss Hafini from Ishtar to present her presentation on lower limb vascular injury.
Okay, thank you, Mr. Ashok. Assalamualaikum and good evening to all the honorable panelists, Mr. Azuddin, Mr. Yuzaidi, Mr. Said Alwi, and Mr. Faizul. Today, I'm Hafini from Hospital Tengku Ampuan Rahimah. Today we'll be presenting on a case, vascular injury, which is one of the successfully managed by our team, vascular injury in Hospital Tengku Ampuan Rahimah. Okay, so we start off with case presentation. We had here a 51-year-old man, Chinese man, who was involved in a motor vehicle crash where he was the motorbike rider. He hit another stationary lorry from behind. He was pale and complained of pain and swollen over the left lower limb. However, there was no open wound noted. His GCS was full, however, he was hypertensive and also tachycardic. At the pre-hospital care setting, 2 large bore granula was inserted and crystalloids were given. So upon arrival to the emergency department, his primary survey was, his airway was patent, he was put on cervical collar. Breathing-wise, there was no abnormality detected. He was saturating well on high flow mask. He was noted to be hypotensive with BP of 97/50 with heart rate of 112. However, he is fluid responder after 1 liter of crystalloid. Abdominal wise, there was abdomen was soft, non-tender. There was no open wound over limbs. However, noted the left calf was swollen and tender. His GCS remained full. His pupils were equal. And noted pelvic spring was positive on the right side. Otherwise, log row, there was no spine deformity, inner tone intact. However, there was a superficial laceration over the base of scrotum. So upon primary survey, which we noted deformity and swollen over the left lower limb, we proceeded with a quick thorough vascular assessment. So we noted that on the left side, the popliteal artery pulses were not palpable and there were no Doppler signal. The capillary refill time was 2 seconds. The SpO2 of all toes ranging from 75 to 80%. There were no sensation, reduced sensation below knee. However, he was still able to move all toes. So at this point of time, our impression was traumatic left lower limb vascular injury, which was a threatened limb, clinically Rutherford 2B, possible injury to the left popliteal artery. So this is the one of the primary survey X-rays. The pelvic X-rays noted a subtrochanteric fracture, but that was on the right side with a inferior pubic rami fracture. We proceeded with the X-ray of the bilateral lower limb. As you can see here, if you look closely, there's tibial plateau fracture on the left side, which extends spiral downwards up until the the upper 1/3 of the left tibia. So before I move on further on our case, this is what we have been practiced in the our hospital. Apart from our normal usual trauma activation, we have another activation where we call it limb threatening activation, activation, whereby any patient who is involved in trauma and there is a suspicion of a limb injury or mainly vascular injury, they will activate as this protocol was derived to mainly to aid or to expedite in the diagnosing a vascular injury and to give a quick management plan to avoid any delay in managing a patient with vascular injury. So this pathway is basically between the emergency department, surgical department, orthopedic, and also our radiology department. Okay, so basically any trauma patient will be triaged the same way based on their life-threatening injuries. So if there is a suspicion of a limb-threatening sign, mainly from the circulation, motor, or sensory examination, they will look for any heart signs and they will activate the limb threatening pathway. So as for our patient, the heart sign was absent distal pulses. So we were activated, surgical team, all the teams were activated, and further management were carried out as soon as we got the referral. So back to our patient, bear in mind he had a suspicion of a left popliteal artery injury secondary to a closed fracture of the tibial plateau on the left side. So what would be your next step of management? So either would you perform a CTA of bilateral lower limb, or would you straight away explore the left popliteal artery, keep in view repair or bypass, or would you treat this patient conservatively as the saturation over the lower limb was slightly low and the motor function was still preserved? Or would you refer to the orthopedic for a stabilization of the fracture segment? Okay, we have the poll results here. Majority of our participants today would do a CTA of bilateral lower limb, and quarter would straight away explore the left popliteal artery, and about only 1% would manage this patient conservatively. So I think either A or B, it depends on the centers or availability of a vascular surgeon. So is there any comment from the our line of panelists on this?
side here. May I know how many levels of fracture on the?
It was a single level fracture. It was a tibial plateau which extends it extends to the upper 1/3 of the tibia.
Okay, I think in the hand of experienced vascular surgeon, probably CTA may delay the treatment one. Most of us will do duplex ultrasound, but I think it is not wrong to do the CTA unless the CTA doesn't delay the treatment. But the CTA is of value when you have multi-segmental fracture, for example, femur, then your tibial plateau, and also distal tip fib. So you want to know how many levels of, which actually segment of the vessels are affected, and you want to know where are you going to land your graft if there is the leg is salvageable and you think that you need to do the bypass. So I think CTA would be the best answer in general.
Any other comments from other
Assalamualaikum
panelists?
and good afternoon.
Waalaikumsalam.
Can I get Mr. Okay, thank you. I will comment first. Okay, I think I think most of the participant here choose to do a CTA bilateral lower limb. So I think that is not wrong. I think it's a good option in a center that you have a very good service for early CTA. But I think, but what Mr. Syed said, if the CTA will delay the process of the intervention, that
Mr. Azudin tak dengar lah. The line is breaking up.
The line is breaking.
Of bleeding, ongoing bleeding in the left STA.
Sorry, Mr. Azudin, we can't actually hear you.
Hello.
Yeah.
Hello.
Yes, Mr. Azudin, we can hear you.
Okay, if there's a open fracture, you have to explore it without CTA lah. But I think it's a common scenario when we all have during our young as a surgeon, that we want to try to conservatively manage this patient, because probably there's some other factors like the distance between your center and the trauma center is quite far, that you have a problem in transporting the patient to that center. Then probably the management of conservative management is the one that you want to choose. But in this patient, as you can see, there's already have some sensory loss for this patient. This patient need intervention. And for the answer number D, the fracture is not that displaced. It looks like a stable fracture. So the probability of the fracture that compressing the probability artery is very low. That's my opinion.
Okay.
Mr. Faisal tak ada?
I think Faisal is here.
Faisal.
Yes.
Yeah, Faisal.
Faisal here. Okay. A and B both can be correct. Depend what you want to achieve, what your purpose. For B, you have a vascular service or vascular trauma surgeon in-house. I think is a good decision because you don't want to delay the surgery in view patient already referred to B. However, if you are in center whereby you have need to refer patient to the other center, I think CTA is a good choice of imaging for this case. Having said that, but you need to push for that to be done earlier and don't wait for the report. Immediately send the image to the respective consultant, vascular surgeon or trauma surgeon for immediate management. So in my center, I will do B. If those who have no in-house vascular surgeon or trauma surgeon, maybe A is appropriate. Thank you.
Can I add one more thing? Sometimes you may anticipate different level of vascular injury rather than at the tibial plateau, maybe higher up. It would be best if we complement the exploration plus on-table or angiogram in replace to the CTA. For those who are actually very familiar with on-table angiogram, it saves time, and then at the same time it actually allow you to plan for your takeoff zone and landing zone. Thank you.
Okay, so like what our experts have mentioned, either A or B, nothing is it can be done, but depends on what center and depends on your clinical examination as well. So for this patient, we proceeded with CTA bilateral lower limb in view of there was no open wound, there was no exsanguinating bleeding, and there's only single level of fracture site. So we would like to delineate the anatomy of the injured popliteal artery. So this is the CTA. Our area of concern is on the left side. So we follow the left side, mainly the right side is normal. So this is the external iliac artery. We follow the external iliac, the common femoral, and it branches into the superficial and also the deep. So we follow the superficial femoral artery, follow it down. So our main concern is the popliteal artery. So as we follow here, you can see okay, as it enters the adductor canal, it leaves to become the popliteal artery. Okay, we follow. Okay, at somewhere at this point, you can see that there is non-opacified distal end of the distal part of the popliteal artery, and there's a faint opacification of the proximal at the trifurcation here, and then there's no it's non-opacified distal to the trifurcation. So essentially the CTA of the left lower limb showed that there's the left popliteal artery, there's a short segment non-opacification roughly about 1.8 centimeter with distal reconstitution, and the ATA and PTA proximally were opacified, but distally were non-opacified, and the peroneal artery, DPA and PTA were non-opacified. So back to this patient. So basically this patient has a vascular injury from a, and also I forgot to mention that as you can see the CTA here, the muscle over the left lower limb is also swollen. It's also reported as swollen. Okay, so back to our patient. So this patient has a vascular injury, clinically Rutherford 2B, and the area or the level of the injury is at the left popliteal, the left distal popliteal artery, secondary to a closed fracture of the tibia plateau. So what be the next step of management? Either would you consider a conservative management as you think that the non-opacification is because of vascular spasm due to following the trauma? B, would you perform the fasciotomy only as would you consider the vascular compromise is due to the compartment syndrome? Or would you ask your orthopedic colleague to put on a back slab of the left lower limb to immobilize the left lower limb and start the patient on intravenous heparin infusion and continue monitor the circulation chart? Or would you refer this patient to a vascular or a trauma surgeon? Okay, majority of the participants today would refer this case to a vascular or trauma surgeon, and about only 1% would manage this conservatively, thinking of its vascular spasm, and about 20% would consider just a fasciotomy and to reassess escalation, I presume, and about 4% just conservative with IVI heparin infusion in the hope that the whatever thrombosis would resolve. So may I have the panelists to comment on this next step of management? What would be the best option at this point of time?
Okay, it's me, Syed. For A, absolutely, there's no role of conservative management, knowing the fact that popliteal artery is the axial artery to the below knee area of the limb. So, in the presence of any fracture, so we should be thinking of the intimal injury as a minimum, and it can be also transection, but you will be able to see that. Fasciotomy is the minimum that you can do. Ideally, you should perform the fasciotomy by looking at the status of the muscle, the soft tissue. When you see hugely swollen and edematous and very tight, without having any symptom, you should anticipate the compartment syndrome before the compartment syndrome sets in. So once actually the compartment syndrome has set in, there's some degree of damage of the tissue ischemia has taken place. So by and large, you have to get it done earlier before the damage is done. See the backstep. Okay, minimal you can reduce the fracture side, but IV heparin infusion is absolutely contraindicated, especially when you have significant muscle crushing, plus you have any transections of vein or artery. And of course, I think the subsequently is to refer to the vascular surgeon, to the trauma surgeon for intervention.
Any other thoughts from our panelists?
I mean, based on your this presentation with the CTA finding, I will agree with Syed. There's no role of conservative management in this case, especially if you have a multiple fracture segment like that. There's almost always there is an injury, whether it's intimal damage, either grade 1 or grade 2. So you cannot just sit on this patient managing him conservative, hoping that one day or after a few hours of observation, there will be a flow. Most of the time, sorry to say, it won't be happening. So especially if there is a fracture segment, so conservative management in this case, I definitely don't recommend. So you either have to explore if your center is capable to do so, or if not, quickly send over to a center who can manage. At the most minimum that you can do is explore and do on-table angiogram to confirm your CTA findings. Otherwise, not for conservative management. Okay.
Okay.
I think,
Azuddin here. Okay. For the answer option just now, I think the conservative management is actually not a thing that you have to do, because you can see from the CTA, the muscle is already have ischemic changes. The muscle is become ischemic, and later on it become a compartment. And then probably you were thought that the SpO2 that was detected because of the, probably there's some collateral, or there's some distal reconstitution of the vessel. But once the muscle get swollen, later on the patient will have a totally diminished flow of blood to the legs. So the amputation rate will be high. So by doing a fasciotomy, I think you can just relieve the pressure, but still you cannot do the perfusion to the all the muscle and towards the legs. Okay, and by putting a back slap for this patient, it's also not indicated. You put the back slap, you put the tight bandage, you will worsen the compartment syndrome for this patient. Okay, that's my thought.
if you can
Okay, congrats to everyone. You answered correctly. But I think, but what I can rationale for those who answer for C, maybe they are in a remote area whereby transfer patient to other center maybe is not feasible. Then then they don't have CT scan. That's the only thing they can do. So yeah, that's it now. But congrats everyone. We'll answer the correct answer. Thank you.
I agree with Faizul. If you are from a remote area and you don't have a CTA, maybe you can start, for example, IV heparin just to buy time. But when you have a CTA already, then C is not the answer. Especially if you look at the CTA finding, there's a popliteal injury proximal to ATA and proximal to your ATA and PTA. Or specified, most likely this is due to the collateral. That's all that they can supply. Beyond that, cannot.
I disagree with IV heparin infusion, because you know that in the presence of trauma, you see there's the patient got trochanteric fracture on the other side, and then you see the patient got tibial plateau. Possibly, I would not infuse heparin. It will rather causing more coagulopathy. You know that actually trauma itself has put the patient to a certain degree of coagulopathic state. So you shouldn't worsen the coagulopathy for this patient.
I have a question to Mr. Faizul. Oh, kau dah jadi Prof. Faizul. You are saying about the. I understand you are in you're the only center in Kelantan for referral for vascular injury. Would you advise the person who having a suspected vascular injury in very remote area, when you want to send the patient, do you advise them to do a fasciotomy first, because they will take time to travel?
Yes, then fasciotomy.
Yeah, just do a fasciotomy.
I give two options only. You want to refer vascular or trauma surgeon, or you want to decide for conservative management, eye tower therapy. If you think that the management think that this patient won't get benefit from the referral or unable to refer, then they can do whatever they want to do. But the fact that you know that the patient may lost a limb, if you think you want to go all out, you try refer to the vascular or trauma surgeon nearby.
But
I would advocate for fasciotomy because rather you won't give extra benefit to the patient. won't give
The problem is
patient
the
is protocol
problem
2B. If you want to do vasectomy, you need to with attempted for revascularization. It just you do vasectomy if you really see the distal flow from the CT scan. The CT scan, you can see the abrupt termination of the flow from popliteal. So your vasectomy won't help unless if in the condition where you can see the contrast at the popliteal artery. And maybe just the trifurcation, maybe you can see a fake signal. So you thinking at that will be a compression, then it may work. But in this case, because you can see clearly this is abrupt termination or contrast at popliteal level, so whatever you do distally won't benefit to the patient. Thank you.
My opinion is that in our KKM hospital, majority of us working in KKM hospital, you might ask that person to do a fasciotomy first. What I feel is that if you do a fasciotomy first, you will easily lose 2 or 3 hours of time just going to do a fasciotomy. So I don't recommend to do a fasciotomy because to post a patient to fasciotomy, then recovery, all these things will take, I don't know, it can take hours. So we will waste a lot of time doing that. So just quickly send to the nearest center as fast as possible.
Okay, I think the take from this short discussion is that when you have a vascular injury, as soon as possible, if you think that the patient needs a CTA, we should arrange that for arrange a CTA as soon as possible and refer to a vascular or a trauma surgeon as soon as possible. Get expert opinion, unless it's clearly a non-salvageable hip. Okay, so what we did for this patient was we decided to explore the left popliteal artery based on the clinical findings and also the CTA findings, which is most probably due to an intimal injury. So the patient was sent to the operating theatre approximately about 4 hours following the trauma. So the next dilemma, so we have decided, so let's say we are in a trauma center or vascular center, we decided for an exploration and subsequently a repair or a bypass with a fractured limb. So the next question would be either should we fix should the orthopedic colleague fix the bone first, or should we, the vascular team or the trauma team, explore and repair first the vascular injury?
Okay, let me answer first. I think the key issue of this injury is...
Mr. Syed, we get the poll running first.
Oh, okay.
So we have here majority would explore first, 66%, and the remaining would fix the bone first. So can we have our panelists to comment on this and to advise on this?
Okay, can I answer first?
Yeah, sure, Mr. Syed.
Okay, the key issue of this problem is the ischemic limb. When you have the vascular injury, you are dealing with ischemic limb. To answer the ischemia is to reperfuse the limb. So fixing the bone does not address the issue. Okay, so in certain cases where you fix the bone first, when the limb is unstable, dangling, and it actually precludes or prevents you from having a good dissection or exploration and anastomosis. So if let's say the leg is stable enough and you can you can perform the surgery and there is no bone entangling or floating in between the dissection, I think probably you will get the reperfusion, explore and reperfuse the leg. So, and in the meantime, if you have any problem encounter, for example, you have a bone dangling, you can get the shunt to be fixated first, then get the orthopedic to come just to fix the bone, not to do the entire procedure, just to make it, render it immobilized, rather than do the definitive fixation, just for you to play around so that actually you can do the revascularization. And if let's say you need to fix the bone, it should not prolong the ischemia. Any other thought, Azudin?
Yeah, I'm quite agree with Mr. Syed. Actually, for me, my concern is who will do the operation first. If let's say you were called in the middle of the night to do this case, and then your counterpart, the orthopedic teams, will take time. Sometimes they will take time. They take their sweet time to do the fixation. It's better for you to do first, because ischemic time is still ongoing. So for me, I'm it depends on cases lah. Sometimes macam case so dangling, the leg is so badly damaged, and then when you try to explore it is quite difficult. But if the limb still looks okay at this point of time, or the trauma is less than 6 hours, probably you can call your senior orthopedic surgeon just to fix it quickly for you to do the operation. But just like what Mr. Syed said, the other trick or option that you can do is you explore the popliteal artery first, and then you identify the injury, and then you put the vascular shunt. You can use a feeding tube, or you can do a proper shunt, and then let the orthopedic come and do the fixation of the bone. Later on, when they finish, then you can do the revascularization and you can do the bypass. The most worrying thing is because when you do your repair, then you after you finish your repair, you let the other thing to do. Sometimes they have to tarik kaki sana sini, then you bypass sometimes can be compromised lah. That is very rare to occur lah, but it can happen.
Mr. Faisal, any comments?
Just in terms of time, another 5 more minutes is remaining. Thank you.
Okay, so I think.
Okay, thank you for the answer. So of course lah, B lah. Okay, how to choose? What you want to achieve basically? You want to salvage the limb. In this case, you see that this patient is rutherford 2B, and the fracture is quite simple, straightforward. So the more you wait, you may convert from the reversible to irreversible damage. So that's why in this case, I think the B answer is the best option. We want to shorten the ischemic time. However, like Mr. Syed said, if a condition whereby the floating bone, patient also the ischemic is just a grade 1 or 2B, then bone first, you can fix first. And for general knowledge, only vascular exploration, we do explore at the medial side, and we give to our orthopedic colleague to explore to do fixation on the anterior lateral side. Okay, that's all. Thank you.
Okay, so there's no right or wrong. It depends on your patient. It depends on the case. So next, another question. This will be the last poll for my presentation. So what's next? So let's say we decide to explore first. So would you perform? So as we know, this patient has a swollen lower limb. So possible there's evidence. To suggest a compartment syndrome as well. So would you perform fasciotomy first, or would you perform fasciotomy after the vascular repair? Okay, so we have almost equal answer. Either one group would do a fasciotomy first and the other would perform fasciotomy later after repair. So what would be the take from our experts regarding this?
Okay. For me, I would always do fasciotomy first. I consider as prophylactic fasciotomy. And it is a safer approach because after you have reperfused the limb, the patient may subsequently develop reperfusion injury plus compartment syndrome. Depend on the severity on the degree of the tissue injury. Even if the patient does not develop compartment syndrome, you can always close it back. And whereas if you explore and then you do vascular repair and then you realize that, you quite hesitate to do the fasciotomy, probably there's some degree of ischemia has taken place. So, and by the time the patient has developed full scale of compartment syndrome, he may develop some kind of degree of the muscle ischemia or the nerve ischemia. So I would prefer B. Thank you.
Okay. Mr. Faizul, any comment on this? Or any other from other panelists?
Okay, follow up side kita. Because this case to be limb swollen. So by doing the fasciotomy also you can buy time to reduce the external compression to ischemic, further reduce the further ischemia to the limb. And if furthermore, fasciotomy is quite fast procedure. Just a few minutes je you can settle fasciotomy. So that's all. Thank you.
For me, I follow the Sifu. No, fasciotomy very fast. You just do fasciotomy and then followed by.
But in condition whereby this a limb not swollen, I think you can attempt explore first.
Yes. Agree. Fasciotomy very fast. Maybe 1 or 2 minutes or so.
I also agree with that.
Okay. So in a trauma setting, almost always it's a damage control. So in this situation, we have a swollen limb, possible compartment. So we would perform a fasciotomy first to reduce the compartment pressure and to reduce the risk of ischemic reperfusion later on. So what we did basically for this patient was we did an exploration of the left popliteal artery via medial approach. So basically, in any principle of vascular surgery, you need to have a good proximal and distal control. So the first picture is you want to get a good proximal control by retracting the sartorius muscle, and the distal control by sometimes we need to cut the medial head of the gastrocnemius muscle, but bear in mind you have to tag the muscles and repair back after the repair, vascular repair. So what was done for this patient? Yes, we did fasciotomy first. This is the picture of just a big picture of the fasciotomy site. You can see here the muscle is swollen, contused, however, it's still viable. So we proceeded with the exploration of the left popliteal artery. Okay. Yeah. Okay, so we already gave the proximal and distal control, LPE. So we noted that from this picture, you can see that the distal part of the popliteal artery is a little bit, we can see externally it's contused, it's a bit bluish here. So we found out that's confirmed intraoperatively short segment thrombosed distal popliteal artery due to possible intimal injury following a tibial fracture. So what we did was we harvested the right saphenous vein and we performed a reverse saphenous vein graft over the popliteal artery. So post bypass, the DPA was 2+ and the Doppler signal was triphasic, and it was followed by the external fixation by the orthopedic team. So post-operatively, he was started on IV heparin infusion for 2 days, converted to antiplatelet. There were no evidence of reperfusion injury post-operatively, and the vascular and motor power all remains intact post-surgery. So subsequently, he closed the fasciotomy wound in stages, and he basically recovered well.
Well done.
Thank you. Any last comments from the panelists?
I've done the job very, very well. Thank you.
In fact, actually, if the segment of the intimal injury is short, you can always do primary repair. I mean, you just resect the segment, but you take the risk of having tension anastomosis. I think it was well done, actually. Nicely done.
Thank you,
Thank
Ms.
you.
Hafini, for the very informative talk, I must say. So moving on, with respect to time, we will now invite Ms. Kalsum from Hospital Sultan Aminah Johor Bahru to give her presentation on upper limb vascular injury. Welcome on board. Kalsum?
Thank you, Mr. Ashok. Just give me a minute. I'll need to share my screen. Right. Okay, so Assalamualaikum and good evening to the honored panelists and to everyone who's attending. Thank you very much for giving me some time in your day. So I'm here actually to present on peripheral vascular trauma, and I'll be presenting cases which involve upper limb. So moving on straight to our case, I've got a 66-year-old Malay gentleman who apparently suffered a fall due to slippery flooring at home around 1600 hours. And apparently he unfortunately had his right upper limb skewered on a nearby garden fence, which he came into a clinic kesihatan, profusely bleeding from the puncture wound on the right upper limb. He was hypotensive on arrival and he had pre-syncopal attacks. But as per what KK could do, they gave him crystalloids and he responded well. But he did complain of some sensory loss. There were numbness, but there was still intact range of movement over all joints of the left upper limb. And they could only do compression bandage over the puncture wound. And he was subsequently referred to a nearby district hospital. So this is the common garden fence that we see around in our country. Nothing very spectacular, and unfortunately he had his arm skewered on one. So in district hospital, he arrived roughly about 3 hours post-trauma, fully alert, responsive. He was already normotensive by then, but still tachycardic, roughly about 130 to 140 beats per minute. And in the district hospital, he was given the first pint of Safe O and responded very well to the blood transfusion. His tachycardia reduced to 60 and 70. So on examination in the district hospital, they found that he had a puncture wound, which was over the medial aspect of the right upper limb, roughly about 3 cm from the lower axillary hairline. Very small puncture wound, measured at about 0.5 to 0.5 cm. At that time, there was no more active bleeding, but they noted that he had very cold peripheries over the left upper limb with a CRT of more than 2 seconds. And apparently the limb was pulseless, but the sensory and motor functions were all intact. And the best pulse oximeter reading they could get was 89 to 90% over the right little finger, over the right index finger, and apparently only 100% from the right little finger, whereas the rest were unrecordable. So the Doppler signal of the right upper limb read at monophasic at brachial level, whereas it was completely absent beyond that at the radial and ulnar. So the next question would be, if you were the receiving team at the district hospital and the managing team, what would your next step be? Would you at that point of time refer the orthopedic team, the local orthopedic team? Would you opt for non-operative management of this limb? Would you send the patient for an CTA, or would you plan for an angiography? Would you explore the wound, or would you actually refer this patient to a tertiary center which had vascular or trauma services? All right. So poll results are out, and I think half of us would probably refer to a vascular or tertiary center, you know, if available. Though I believe some who answered angiography or CTA probably were from centers that actually provide these services. So any comments from our panelists in regards to the poll results?
Oh, yes. Can you hear me?
Yeah.
Hello?
Yeah, Mr. Azudin.
Okay. Macam masa saya nak cakap tu. Tak boleh saya cakap dulu.
Okay.
Okay, I think that this to summarize, this patient actually having some form of vascular injury. This is confirmed by the your clinical examination. Completely is a vascular injury. So if you are in a district or in other remote area, we don't have a vascular or trauma service, then option to refer is a very good option to refer early before the things get worse. And for us, I think we don't. This is a single puncture injury. It will not involve any fracture of the bones. So exploration of the wound for me is I will go for the exploration of the wound rather than try to do a CTA. That's my thought.
Yeah, it is actually a penetrating injury to the vessel. So the key thing is actually there is no other injury that you might encounter unless there is concomitant fracture blunt injury. But with this penetrating injury, I think the key thing is to get it explored in the center where there is a trauma surgeon or vascular surgeon. CTE is actually of no use. It just delay the management, especially in the patients profusely bleeding. Thank you.
Okay, just a point to what bottom point. In this case, it's quite straightforward. But most of the time, the patient is penetrating injury to the arm. A lot of cases presented with hypotensive episode. So when you have a penetrating injury like this and profuse bleeding, CTA is out of options. Get it explored. Some centers have don't have a surgeon but have an orthopedic surgeon in which they can handle. It is also can, but if the orthopedic surgeon can it's not wrong. I know because some center vascular repair is done by the orthopedic surgeon. But don't delay by doing an angiogram because it's quite straightforward.
Two, you need to know the location of the injury. For example, the penetrating injury is there, and then you know there's a vessel there. Like a penetrating injury to the thigh.
Injury to the lateral aspect, okay, you may want to investigate, but a penetrating injury to the medial aspect of the thigh, you know, the big vessel is there, so no point doing an imaging. That's my thought. Maybe Faizal ada opinion lain.
Okay, two issues in this patient: penetrating, so bleeding. Second, ischemic. So need urgent intervention. If your center, you can do repair, so you can explore wound and do the subsequent repair. If you can't do repair, just explore only, we won't give any benefit. Otherwise, prefer the tertiary center is the best management.
All right. Thank you very much to the expert panels. Moving on. So this patient actually arrived in a tertiary center, and he was alert, responsive on arrival. Hemodynamics were good, and reassessment of the right upper limb showed that the right upper limb was cooler in comparison to the contralateral upper limb, and the CRT was less than 2 seconds. And we could actually get pulse oximeter reading more than 95% for all fingers of the right hand. And however, pulses of the right upper limb were not palpable from brachial onwards. The Doppler signal actually showed that the right upper limb in comparison to the left upper limb was impaired quite significantly all the way down to ulna. And this was the picture of the puncture wound. As you can see, it's actually a very small puncture wound, but bear in mind, this is a penetrating injury. So I'm sure many of us are quite familiar with the signs of vascular injury, where we generally look for hard signs or soft signs. And this patient actually presented with more soft signs, actually, where he had diminished pulses distal to the injury. He had a stable, small hematoma surrounding the puncture wound. And it's a very close proximity to major vessels, as we know, because the location would indicate that it's very close to the axillary artery. He did not have peripheral nerve deficit in terms of motor, but there was some sensory deficit, and he had history of hemorrhage at the scene. However, bear in mind, when he came to the tertiary center, he was no longer actively bleeding. So where would we go from here in a tertiary center? Would further imaging benefit this patient? And if so, what imaging would you choose? Duplex ultrasound, CTA, or would you opt for a traditional angiography on table? Or would you take the patient straight for surgery and explore? I'm not sure if we have a poll for this. Do we have a poll for this? Right, okay, so no poll, but any comments from our expert panel? Would you like to give an opinion before I move on to what we did for the patient?
Okay, looking at the scale or the magnitude of injury, this is just a simple puncture, but it could be both arterial and venous injury. So most of the time, the site of the puncture indicates where is the level of the trauma. So I would do duplex ultrasound, no CTA, no need angiography, and proceed with the surgery.
So distal to the shoulder joint, so duplex ultrasound can give accurate finding with the CTA. Just duplex ultrasound and proceed with the surgery. Unless we suspect more proximal to the shoulder joint. You suspect is a proximal lesion, subclavian, or even aorta, then CTA give benefit. Otherwise, you just distal, then ultrasound duplex is adequate to plan for further management.
Any other comments from?
Because we can do our own duplex, and not duplex by radiologists.
Understood, Mr. Faisal.
Agree.
All right, so in the interest of time, I'll move on. So rightly so, we actually proceeded with wound exploration for this patient, took him to OT. We managed to actually, we had to go through muscle and explore the wound, and found that the patient actually had a third part axillary artery injury, in which he had more than 50% laceration of the third part of the axillary artery injury, and there was a large hematoma surrounding the arterial injury site. But at that point of time, the vessel had already thrombosed off, and there was no active bleeding per se. And if we actually use the AAST scoring for this patient, it would be a grade 5 injury with an AIS score of 3. So as you can see from the AAST grading, involvement of major arteries of axillary artery, common femoral artery would be a scoring of at least 3. So now we found out on table, this patient has axillary artery injury. What next? Would you opt to bravadely ligate the axillary artery? Would you attempt a primary repair? If so, would you repair it via graft? Or would you repair it via what kind of graft? So I think, yeah, there's a poll for this. So let's see what the poll says. Okay, so I think it's quite rightly equally divided. Some would attempt a primary repair, and a good half would actually use a graft repair. So bear in mind, the vessel was not completely lacerated, it was not completely disconnected, but it had more than 50% circumferential involvement. So any comments from my expert panel? I mean, what would you attempt at this point of time? Would you risk primary anastomosis, hopefully tension-free, or would you not take the chance and use a graft?
If let's say the injury is less than 2 cm and you think that you can achieve tension-free anastomosis, then it would be nice to have a primary repair. But if, let's say, there is a slightest thought that there is a tension in your anastomosis, probably the native graft, it would be good.
I will prefer the interposition graft for this patient,
right?
Because the limb is, the upper limb is at the axilla area. Patient usually move quite a lot, takut ada tension,
Yeah,
and
true.
compromise the repair.
Yes, if the defect is quite short and you can get tension free, this primary repair is the best. But if you think your repair is too tight with tension, then you need to add the interposition graft, and preferred still the native graft lah. But you can find the nearer vein, so you can find the basilic vein nearby. If you can't, I just want to add one question from the chat from the Dr. Faiza regarding the to explore in the penetrating wound. I answered that life before limb. In condition whereby you encounter with penetrating vascular injury, you will think that the bleeding is so severe as aggression, then you have to explore to control the bleeding while preparing patient to refer to the shield center. If the bleeding can control by whatever means, by compression or conservative, then no need to explore. So keyword is, if you think there's a bleeding or you can see the vessel spurting, then control the bleeding is priority rather than referral or revascularization. Life before limb, always.
Faisal, would you prefer a tourniquet? If the bleeding is very torrential, will you prefer a tourniquet before they sending the patient rather than you?
Your door has got everything.
Or Mr. Said, will you prefer a tourniquet? Let's say person in district is bleeding torrentially from the axilla. You don't have experience on explore. Will you use a tourniquet to stop the bleeding?
I think if tourniquet is one of the ways of reducing torrential hemorrhage by applying the compression over the site. Unless you have the luxury to explore and bring to OT and stop the bleeding, unless if it is in the ED setup, I think tourniquet would be the best.
Yeah, I agree also, because life before limb, just what Mr. Faisal said. Tourniquet, although it can compress the upper limb, but can save the patient life. I think Mr. Yus is very into this stop the bleeding cause.
Okay.
There's an option of ligation.
As like what Mr. Faisal said, if patient is torrentially bleeding and unstable, ligate, because you axillary artery have a lot of collateral to the upper limb. So only for torrential bleeding unstable, okay, you can ligate life before limb. That's always the principle. If the patient is stable, don't have to ligate, you just do a compression. How about the tourniquet? Okay, if you want to apply a tourniquet, the key point is that don't apply a tourniquet for more than 2 hours. If your journey will take you 4 hours, please just do a compression. Don't apply a tourniquet. No, after 2 hours, it will cause a neuroplexia. The nerve will be damaged.
Yeah, true.
Just be very careful. No, you want to save the patient, the limb is viable, but paralyzed. No point. Okay? So you want to apply tourniquet, apply proximal to it, and make sure you don't apply more than 2 hours. And then if you want to apply tourniquet, make sure you write the time. When do you apply the tourniquet? That is very, very important. That's the key point here. Only for provincially bleeding patient. If you can apply a pressure by applying a bandage or with your fingers, that's good enough. You do not have to apply a tourniquet. I hope that will answer the question. You dengar tak?
I think if those who have the operation theatre can explore the bleeding as part of the resuscitation in the district hospital, for example, then it would be best to do that. I think tourniquet is like the cheapest and the easiest thing without having the anesthetic part to help you out.
Yeah. Like for example, in this case, this patient travel all 150 kilometers away. But good, the good thing is about upper limbs that they have a lot of collateral, which is very, very good. Okay. Next. Dengar tak?
So just a few provocative questions that I kind of thought of when I did the presentation. If the option of ligation is there, would you dare do it? Can it be ligated? Primary repair. And if you can't do primary repair, then what suture would you use for your interposition graft? Or even if you do primary repair, what sutures would you use? And if you are going to use a graft, what material is best, vein or synthetic graft? But I believe that our expert panelist has already mentioned before that best, of course, would always be the natural graft. That means our vein graft. And is there any role of endovascular therapy for this particular penetrating injury? And would any of my expert panelists like to comment on the last question that I put up? Because I think we've went through the third question, but I have not given any thought. I mean, they have not given any thoughts on role of endovascular therapy for penetrating injury. Would you agree? If so, if not, why?
Okay. Axillary artery is the medial artery of the upper limb. So to ligate, you are going to compromise the perfusion to the arm and forearm. You can ligate the brachial artery provided that the profunda brachii is patent. So there is presence of profunda brachii, but not axillary artery. So the next question, the primary repair. When cannot do primary repair?
No, I think there's a bit of a typo. If doing primary repair, what suture would you use?
What suture do I use? I use 670. And preferably the native graft. Either we take the saphenous vein, or you can get the basilic vein or the cephalic vein. And role of endovascular therapy, yes, if you have the expertise whereby you can use through the brachial artery approach, and then you can use the covered stent to seal off the perforation.
Mr. Faisal, any thoughts on endovascular therapy for cases like this?
Any rule? Yes, of course, the rule. But very limited lah. As long as the vessel stay intact, There's no totally transected or partial transected. As long as you just have a small hole there, or patient have pseudo, then what Mr. Said said, you can put stent to cover the defect vessel.
But this is with the
Yeah.
caveat
Even
that the
if you
patient has
plan
gone for
to
CTA first, right?
the bleeding side, you can use endovascular, but rarely be done. Otherwise, same.
All right, thank you.
Sorry, Kalsum, with regards to time, can you quickly wrap up? Thank you.
Sure. So for this patient, we actually opted for primary repair and using Prolene 6O sutures. We managed to achieve tension-free. There was adequate muscle coverage, and post-anastomosis, the Doppler signal was triphasic from brachial onwards. So patient actually was well, unremarkable recovery, and he was started on single antiplatelet and was discharged home at post-op day 3. We anticipate to see him back at about a month in our clinic. So this was a provocative question that was given by one of my surgeons. Can we ligate the axillary artery? So I think Mr. Said has rightly so answered, and in the interest of time, we shall move on. There's actually a second case, a very quick one. A 27-year-old foreigner who sustained degloving injury of the left upper limb, secondary to an RTA. He came in hemodynamically stable, but clinically was unable to have, had distal pulses absent. He was referred to the orthopedic team from a district hospital, and unfortunately took a while for him to reach the tertiary center, which he arrived post-trauma 12 hours. As you can see, it's quite an extensive injury involving skin, subcutaneous tissue, muscle, and we believe that there was also neurovascular bundle involvement. And so what next? 12 hours, he's got probably a mangled limb. Would you opt to amputate this patient? Would you explore this patient? And so I think we don't have a poll for this, but the discussion that went on to the tertiary center and the trauma center who received was, he wanted to evaluate the situation first. So the patient was transferred from the district hospital to trauma center and eventually had actually undergone exploration. So it was a heavily contaminated wound. The proximal brachial artery injury was grade 5. There was a loss of segment of about 4 cm. There was also nerve involvement, transected median and ulnar nerve. So what we did for this patient was we did extensive debridement, embolectomy, and there was good inflow and backflow distally. And we actually ligated this patient. And however, the orthopedic team came in and tried to repair the nerves. And surprisingly, the next day, the patient actually could retain some motor function. And the radial and ulnar signal were biphasic with a good pulse oximeter reading on all 5 fingers. And despite the ligation, the patient still managed to retain his left upper limb. So that's a thought. Just like to share a little bit of statistics on peripheral vascular trauma in my center. Over the last 10 years, we've actually received over 186 cases with predominantly more towards the lower limb. And we've also got a fair share of upper limb as well. So it's quite common to have peripheral vascular trauma. I'm looking at about 18 cases per year, not very rare at all. So like to thank my expert panel for all their opinions and their suggestions. And I learned a lot, and I hope everyone else learned a lot as well. So back to you, Mr. Ashok. Thank you.
Thank you, Kaushal, for the informative presentation. Now moving on, we would now invite Ms. Tiong to share her thoughts on the approaches and the management strategies of vascular trauma. Welcome, Tiong.
Tiong, please unmute your.
So sorry, I forgot to unmute. Okay, let's start again. I'm Tiong. I'm a trauma surgeon here in HSTAR. I will just present something on how we approach peripheral vascular injury as a whole. I'm directing it towards people who don't really see vascular injury on a regular basis. So once in a while you get those kind of cases. So sometimes you are not quite sure how to go about it, or are you thinking, am I missing something or am I doing something wrong? So I just hope to give a little bit of a structure to how your decision making and your assessment skills are. So hopefully at the end of the day, you learn a little bit and be a little bit more confident in how you approach patients with peripheral vascular injury. Anytime that the panel feels like they want to give a comment, just feel free to butt in. Okay, so I will talk about essentially three things. Diagnosis, when do you need to think about a possible vascular injury? Number two is how you work that up to confirm or refute your diagnosis. And then a little bit about the operative aspects of vascular injury repair. Right, so three questions I think in general that you need to be able to answer at the end of your assessment. So number one, is the limb viable or not? Number two, if it's viable, is it salvageable? And then number three, to plan your operative roadmap, you need to know where this vascular injury is. Is it a single level? Is it multiple levels? And then after answering all these questions, we'll try and give a little bit of structure on how you make decisions and do what is best suitable for the patient. So starting off with diagnosis, when do you need to suspect that is there or is there not a possible vascular injury? Clinical suspicion. So first off, by the mechanism, you should be able to have a rough idea of yes or no. Very, very obvious, very dramatic, prominent mechanisms will be penetrating injuries. So things like this, that's an impalement into the limb, you need to think of that. If it's obviously a very badly mangled limb, you need to think of possible vascular injury. Sometimes things are not that dramatic. You can have a closed fracture or a hematoma. This is a patient who essentially had his handlebar jammed into his groin area, leaving a mark like that. So just below that will be your groin vessel. So you need to confirm whether are they injured or not. Fracture patterns. So tibial plateau fractures like this, the popliteal artery is just behind it. So you will need to exclude arterial injuries. The other classical mechanism for popliteal artery injury is knee dislocation, posterior knee dislocation. So if you have a patient who has a posterior knee dislocation, please think about consideration of popliteal arterial injury. So this is just by mechanism alone. A little bit more objective on clinical assessment, very classical. You have the hard signs of vascular injury as well as the soft signs. So hard signs are the ones which are very obviously a bleeding vessel. So you have an active pulsatile bleeding. It can be a close injury, so you get an expansile or a pulsatile hematoma. A bruit or a thrill would lead you to suspect that is there a possible traumatic AV fistulas. And of course, the classical six P's of an acute limb, these are the ones you need to assume that there is a vascular injury rather than not. Soft signs are the ones that are a little bit iffy. So you got to think of maybe there is a soft tissue, there is a vascular injury. So things like a small hematoma which is not expanding, or if the hematoma is near to regions where major blood vessels run, suspicious fracture patterns like the one that I mentioned earlier regarding the tibial plateau as well as posterior knee dislocations, pulses which are not as strong as expected if comparatively to the other limb, abnormal ABI of less than 0.9. So these are all soft signs. So as I mentioned before, hard signs more or less kind of confirms a vascular injury. This kind of patients, consider bringing them to OT straight. Soft signs are the ones that you need to query, is there not a possibility of vascular injury? And studies wise, patients who have soft sign, about 25 to 35% of them actually have vascular injury. So you need to consider. And these are the patients who, because you need to rule out vascular injury, they will probably need to undergo further imaging to rule in or rule out a possible vascular injury. Okay, so on your workup, once you have a diagnosis, 3 questions that I mentioned earlier. Number 1, is the limb viable or not? The Rutherford classification is something that's pretty standard. Rutherford classification, this is for acute limb. So you have class 1, 2A, 2B, 3. In general, if you can't really remember it very well, easiest way is essentially class 1, you do have time. No vascular, no sensory, no motor involvement, you do have time. So you can take your time, well, not too long, but you can have a certain amount of time to actually work up the patients. At the end of the list, class 3 is essentially, it's a bit too late already. The limb is not viable, so it's a dead limb, and there's nothing much to do other than to take the limb off the patient. The ones in the middle, class 2 and class 3, these are the ones which are threatened. Something needs to be done in a relatively fast manner. In general, if sensation is impaired, but motor is not, it's a 2A. And if you have both sensory and motor impaired, that's a 2B. So that's just a very easy, fast guesstimate in ED when you see a patient who's been referred to you. So question number 2 is, if the limb is viable, is it salvageable? So this is a picture of a guy who essentially has his arm literally twisted off. So this is his shoulder, that's its elbow. It's an open fracture, so the elbow joint essentially has been dislocated and pried off. That's the distal condyle of his humerus. His brachial artery has been transected. His radial nerve has been transected. His arm is twisted in this very abnormal position. It looks pale and it looks kind of not very good. So the question is this limb salvageable? What would the audience think? If we can have the poll, it's either a yes or no question. So just based on the clinical information that we have, are you able to answer this question? We have the results of the poll. A vast majority of the participants think that this is a limb that will not be able to be salvaged. This is actually a relatively gray matter because it depends a lot on who you have and what services you have. So in this case, this was actually a case report. So in their center, they had the brachial artery repaired, they had the radial nerve repaired, they put an X-fix on him, and the last picture is about 18 months down the line, and his function is still intact, and it is considered a pretty functional limb. So this is actually not a yes/no kind of answer. It depends a lot on the factors that is in context. How long was the patient left without medical care, what services you have, how good is your rehabilitative services. So a lot of gray area. So essentially, this is the answer. This is a question that you will have to answer based on what resources you have at your disposal. So if you think that the limb is salvageable, then yes, go ahead and salvage it. But if you think that your services cannot offer him any help, then it is essentially a primary amputation. So as I mentioned before, there are a lot of factors to consider. Local factors at the injury site. What is the condition of the blood vessels, the bone, the nerves, the soft tissue cover? So this is all local. Systemic things you also have to consider is how stable is that patient, because for a vascular, a nerve, and a bone repair, it will take considering many hours in theater. So is the patient stable enough to actually sustain that? Are there any concurrent injuries? So it's not a yes, no answer, but depending on what you have, you need to come up with your answer. So there are some objective scores to help guide you.
Okay, Faizul, yeah. Majority answer correct, because based on majority of the center, the condition will be non-salvageable. Having said that, if we know any center that can salvage the limb, so it's good for us to try attempt to refer that center, because this injury involve the upper limb, and we know that the upper limb is more precious than compared to lower limb. Furthermore, if the dominant hands, so we try hard to salvage the limb. Having said that, I just to inform here that also, luckily in USM, our plastic team, we have good reconstructive team. Even they can repair, vascular repair, those who are degloving injury, nearly amputated limb. They have a quite good team with the orthopedic, so they can try attempt to salvage in case where they need patients have a potential to heal. That's all. Thank you.
Yes, I do agree. A mangled limb is essentially an entity that needs to be approached in an MDT approach. So there's multiple disciplines that can actually offer help to these patients. So I guess it would depend on where you are. If you are at the center with an MDT team with you, then yes, that is an ideal situation for the patient. If you happen to be in a hospital, let's say in Sandakan, where you do not have a vascular or a plastic team involved, then that patient in that context will probably end up with a primary amputation. Okay, so back to scoring systems for mangled limbs. There are actually many scores. One common one is actually the MAS score. So this takes into effect the local factors, which we mentioned earlier. How long has the ischemia been there? How the systemic condition of the patient is, and in terms of age, because that gives an idea of how much reserves they have. Traditionally, anything more than 7 is non-salvageable. So traditionally, they would recommend amputation if it's more than that. But recent papers have been coming up to say that the MAS score actually is, it was, I think, established in the early 90s. So that's roughly about 25, 30 years ago already. And essentially medical care has progressed. So there are some institutions who actually don't strictly follow the cutoff points, but in the middle areas, they will attempt. So again, it depends on what resources you have at your disposal. So this is something that's a bit objective.
John, can I say something about Mango score?
Yes.
The MAS score. This MAS score has been misused by, I'm so sorry to say, some irresponsible surgeons that actually try not to work hard to reconstruct the limb or to salvage the limb. I don't want to, pointing towards who they are, but if you look at the age factor, you see, if it is in the pediatric group, it is not even salvage. It is not even we call that applicable, especially when the BP is so low. See, systemic BP, always 90, isn't it? Hypothetically not applicable in pediatric. Age factor also, and the other thing is that it is not applicable in upper limb. And upper limb has its own special blood supply, namely in collateral in the shoulder joint. So if you have the injury to the shoulder and or upper limb, they are still most likely that the hand actually can withstand the ischemia longer than the lower limb. So mascot itself is not a very good, but it can be used as a guide. Based on my papers before, as a brachial artery injury, most 70% of those actually arrive in our center and arrive in OT after 6 hours. And we managed to salvage about more than 75% of cases. So it looks like if we work hard and we try to strive to the excellent, mascot itself can become obsolete. If we have a good team, orthopedic, trauma surgeons, and they really want to, salvage the limb, mascot is like, for me, it is not applicable anymore. So we have to find new scoring system that actually valid to be applied in the next 10 to 20 years ahead, rather than using the backdated scoring system.
Yes, then there has recently been a trend to.
Hi, Tiong. Hello. Okay.
Yes.
To prove Syed's point, Kasum has presented the second case in which patient came to us more than 12 hours with upper limb injuries. Limb still can be salvaged, like what Syed says. I mean, there are good collaterals. Even though if you see that wound looks like the if you score based on that score, the muscle like badly injured, kan? But upper limb has a very good outcome compared with lower limb. Even though the patient came to us for more than 10 hours, except whether you want to do it or not. So there are other score that you can use. I think other than this score, you can go up. Okay. Thank you.
Yes, I agree. Upper limbs tend to be more tenacious than lower limb. Okay, all right. So the third question I mentioned earlier is essentially to confirm where the level of the vascular injury is, and is it a single level or multiple levels? So on clinical assessment, you can probably give you a rough idea in the sense of are your pulses palpable. So in principle, anything pulses proximal to the injury will be unaffected, and anything that's distal to the injury will be either reduced or absent. And the Doppler signal will probably give you some correlation as well. So that's for clinical assessment. But to get an objective level of where the injury is, there usually will be radiological studies needed. So one question to ponder is imaging always required before surgery?
Is imaging required before surgery?
Okay, a vast majority of the participants say that no, imaging is not always required for surgery. It's one of those trick questions in medical where always is never really correct because anything can usually happen. But I think the best context would essentially, what is the context of your vascular injury? So as the case mentioned before, so cases like a penetrating injury, you know where the site affected is. Cases like this, you will not do a CTA before going into theater, in the sense that it will not add anything extra. So penetrating injury, single point, identifiable vascular level, then CTA will probably not help you. There are certain cases where a CTA will be useful to you in the sense that it helps you to plan your operations. So cases like closed fractures, multiple levels. So example, a closed femur fracture, a closed tibial plateau fracture, you need to find out where is the vessels involved. Is it at the SFA level or is it at the popliteal area? So cases like this, then yes, a CTA would be helpful to help you plan where to cut, where to make your incision. So again, not a yes, no kind of question, but kind of depends on what the context is. So radiological studies essentially can help you confirm a vascular injury, and if it's something that is not too significant, you may not need an operation. If there is a significant vascular injury, number one, it will confirm that for you. Number two, it will tell you where it is so that you can plan how to go about repairing this. So what kind of radiological diagnosis, what kind of radiological images can you actually order? So for vascular injury, it's essentially a image of your blood vessels. So that's an angiogram. Two ways of doing it. At the moment, the easiest, fastest, most widely available form would be of a CT angiogram. The other traditional form is essentially a catheter based, meaning that you have to get vascular access, put up a catheter in there and push contrast through that. This may not be available in a lot of KKM hospitals. The advantage of it is that it can be done on table so that you can make decisions on table itself. There are some papers who actually said that DSA is actually better in terms of reducing scattered artifacts. So sometimes when you do a CT, if there are metal bits around, there will always be scattered artifacts. So sometimes the radiologist may not be able to properly see the contrast flow. So this can be done preoperatively, or it can be done on table if you have the fluoroscopy services available. So what are the things that you can actually see? So an angiogram essentially is time, the phase of it is time when the contrast runs through the arteries. So you will get, essentially what you see is contrast. So this is a reconstructed CTA reconstructed view. So that's vessels. Well, actually, theoretically, if you want to save, technically what you are seeing is actually the contrast. So you are seeing the flow of the contrast, and from the flow of the contrast, you are making an inference on what the condition of the blood vessel is. So you can see filling defects just an abrupt cut off like that. And you can see other things as well. So if you see abrupt cut off like the pictures before this, you need to think of two things. One is whether is that a contusion, meaning that there is an internal injury, or is it a transected vessel, because they will, both of them usually on the CTA will just appear as an abrupt cut off. The difference essentially is contusion is usually an internal injury. So the outer layers are actually okay. But because of the internal injury, you get a blood clot, and therefore that subsequently obstructs the flow of the blood to the distal limb. Transaction, what happens in transaction for arteries? Usually what they do is they go into spasm. So you will have a circumferential loss of the vessel wall, but the vessel wall will constrict and you won't get any more active flow from there. So on the CTA itself, you will just see an abrupt cut-off point of the contrast. On the other hand, you can also see active bleeding. So if you have an active bleed through there, you will see an extravasation, which is right there. So that's an extravasation. So that's a contrast extravasation. So that's a pseudoaneurysm there. This is a guy essentially who had a gunshot wound to his groin 2 weeks ago. So in an arterial phase, you should only see the arteries. So on the left side, that's just the artery, but on the left side, on the arterial phase, you can see contrast both in the artery as well as in the vein. So cases like this guy actually has a traumatic AVF, and that's just supplementary with the Doppler, so you get Doppler signal flows in both the arteries and the veins. So these are the kind of lesions that can be picked up on radiological imaging. So if you have answered those three questions, viability, salvageability, and the level of the injury, what's your next step? So management, again, is based on many factors, how the patient is clinically as a whole, and then on the local scene, what blood vessels are involved. Is it a complete one? or is it a complicated fistula? So depends on what the CTA tells you. At this point in time, you should be thinking of a possibility of requiring surgical skills in the sense that these vessels will need to be repaired. So if you're in an area where there is no vascular or trauma services, you have to think early down in when you first start to see the patient, what are your capabilities of providing surgical care? Where is your closest referral center? Will the patient be able to reach a referral center in time for the limb to be salvaged? Is there a role of putting in a shunt if you have the services of doing that? So these are the questions you need to ask yourself, especially if you are not backed up by vascular or trauma services. So vascular injury, it's time consuming, it's technically demanding. Factors depending on what the context is. So in a nutshell, your mode of thinking is essentially, is the patient for definitive repair, or is the patient unable to tolerate a long surgery and therefore you have to go into a damage mode, damage control mode, meaning that either you ligate it or you shunt it. There are more and more papers now coming up regarding endovascular stents. And if you have a center where there's IR available or a vascular surgeon who is familiar with endovascular shunts and all the
just if you don't mind, just another 5 more minutes, I will wrap up. Thank you.
Okay, I will definitely run over time, but I'll try. Okay, so endovascular shunts are actually quite useful for junctional areas. So the subclavian, axillary area, junctional areas in your groin. So those are nice things to have. All right, so taking a look about definitive repair, as I mentioned before, depends on how big your hole is and is there any gap distance between them. So what are the options for definitive repair? The closest, simplest one would be essentially be a patch repair. So that's your graft. So essentially you open the graft, you cut it down to size, and essentially you make a patch over it, okay? So if you have a vessel that is transected, but the gap between them is actually very minimal, maximum one, some people would actually push it up to 2 cm, then you can actually debride off the edges, thrombect on both sides, and do a primary anastomosis. The important thing is it has to be tension-free, because if it's under tension, number one, it will thrombose off. Number two, there will be bleeding from your suture holes. So if you have an area with minimal gap between the two vessel stumps, then yes, you can do a primary repair. If not, if it's too far away, you can consider doing grafts. So it can be short grafts, like an interposition graft, which is this one. So there's an end-to-end anastomosis, or if not, you can consider a jump graft, short jump grafts. In general, in trauma, the shorter the graft, the better. Sometimes you do not have, you have a further gap, especially for popliteal injury. So what you can do is essentially a non-anatomical bypass. So for example, most commonly for popliteal vessels injuries, we do a SFA, PTA bypass. And essentially that graft doesn't run in its usual anatomical course. Right, so a little bit about the preoperative planning. So prep is very important, and you should always prepare to get proximal control. So in the upper limb, you want to prep from the neck, contralateral nipple, all the way until the bilateral fingertips. Lower limb, prep all the way from the umbilicus and bilateral lower limbs, because you will always need to consider whether you need to potentially harvest the other leg. In a trauma setting, for grafts, for saphenous, native saphenous venous grafts, we usually take on the unaffected side, because if you do have an arterial injury on one side already, you do not want to further compromise venous congestion on the same leg. So in general, for trauma patients, grafts are always from the other leg or the hand if you do not have the other leg to work on with. Principle in vascular injury, always get proximal and distal control. So if you have a large hematoma, example, over the knee, you want to make an incision over the SFA to get proximal control, and then on the distal, popliteal or distal PTA to get distal control, rather than making one big incision over the hematoma. So if you do that, you run the risk of actually having uncontrolled bleeding once you release the hematoma and the tamponade effect, okay? It's very important to prep the vessel stumps, meaning that all internal injury has to be removed. Make sure that there is no mural or intravascular hematoma, which is why you always thrombect Fogarty catheter, proximal and distal, and all adventitia has to be cleaned off, so it has to be really, really nice and clean. Regarding conduits, if you have the ability to get a native graft from the other leg, this is always the best for the patient. Native grafts are superior in terms of long-term patency, and your reduction and the risk of infection is actually lower. Sometimes you don't have the luxury of getting a native graft, so you would have to consider synthetic grafts. The other thing to remember is that you should not put a synthetic graft in an area that's contaminated, because it's always a risk of a foreign material getting infected. Always have tissue cover. You cannot do a graft and leave it open, exposed to air, because that graft is going to dry up, it's going to die, and it's going to thrombose or either start bleeding. So always have tissue cover over your grafts. And fasciotomy is something I think we mentioned before. It can be done before, especially if you have concerns about the viability of the distal muscles, especially if there's been a long period of time from injury. So fasciotomy is something that you need to keep in your toolbox of approaching vascular injury. So that's for definitive control. Damage control is essentially when you don't have the luxury of long theater, or you do not have vascular services and you want to refer the patient out. Two things you can do is either you ligate it off or you put in a shunt. Ligation, if it's compromising the patient's hemodynamic status, then it's a life over limb scenario. The thing about ligation is that most of our limbs essentially has multiple blood vessels, especially distally. So there's always an anatomical redundancy. So example, in your upper limb, you have your radial and ulnar. So if one of them is actually functioning, you can ligate off the one that's bleeding away. Shunts are the patients you need to consider. So if you know how to put in a shunt, that's actually a very good skill set to have in your surgical repertoire. So patients who are unstable or who has very complex, very dirty, contaminated wounds, or potentially it needs a very complex vascular recon, these are the ones that you would want to consider putting in a temporary shunt. So a little bit about shunts. Shunts is essentially any conduit that joins the proximal and the distal limb. So you do have commercialized grafts available. This is an Argyll carotid shunt. So you can use shunts like this. In hospitals which do not have these shunts, you can always improvise. So you can use things like a pediatric feeding tube. You can use Rouse tube. If you have large bore vessels or veins you want to shunt, you can also use chest drains. So as long as it is a shunt that is relatively rigid enough to hold for your stumps, you can use them. Okay, it's if possible, always try to use the largest shunt available to you, because the bigger the caliber, the other way of thinking about it is the smaller the shunt, the smaller the diameter, the slower the flow, and the faster the risk of thrombosis. So use a shunt as large as you can find. A little bit about how you want to put it in. It's always nice to mark in the middle, so you can do it with a marker pen or a suture, so that when you put in, because when you put in the proximal and distal one, you kind of lose how much length has actually gone into the vessel. So it's nice just to mark the middle of it. It's very important to prep both the limbs. So just trim off your stump. Always do a thrombectomy proximal and distally, because your whole intention of putting in a shunt is actually to establish temporary blood flow. So if you have a blood clot in the proximal limb and you don't remove that, there's no advantage of putting in a shunt. It's always nice to put in the proximal limb first, secure that, and then the distal bit. So essentially what you do is, that's the middle of your shunt, so you mark that. 2 cm goes into the proximal, into the stump, ligate at 1 cm. So how long your shunt is will be a minimum of 4 cm plus the gap that's in between those two vessel stumps. So if you do it well, you do it properly, the reported incidence of the shunts getting thrombosed is actually pretty low. So if it's something that you know how to do, you can actually buy a little bit of time for patient to transfer. Certain things that you have to understand that if you put in a shunt, number one is that you definitely will need second surgery for definitive repair. And number two is you will need a little bit of tissue to be removed and debrided when they do the definitive vascular repair. So there will be a little bit of a tissue loss, and therefore your gap in between those two stumps is actually a little bit wider for the subsequent vascular or trauma surgeon who will do the definitive repair. And going to theater after bypassing everything is not the end of the story. Post-operatively, always remember to monitor the patient, because arteries can always thrombose off. So that can be done clinically, and it also can be conjugated with a Doppler reading. Aspirin-wise for post-bypass patients, this is actually based on patients with IHD post-CABG. So I think there are people who actually practice given antiplatelets just to make sure that the graft stays patent. Can you manage any vascular patients, any vascular injuries conservatively? This can be a little bit debatable, but essentially patients with soft signs and on the CTA, there is still flow running distally to your level of vascular injury. Some people will give it a try of non-surgical management. Then you'll need to discuss about the role of antiplatelets or anticoagulants. And in the long term, is there any implications? Will they develop arterial insufficiency later on? So these are all the questions that will need to be answered. This is actually a nice paper if anyone is interested. So essentially it looks at pitfalls on what are the things that goes wrong in managing peripheral vascular injury. Giving a little bit of structure to your thought process, there are algorithms out there. This is actually by the WTA, the Western Trauma Association. This it's one of the major trauma associations in the US. So they've come up with algorithms like this. So this is always something nice to have in trauma. This is essentially what we have gone through. So hard signs and soft signs, and based on that, what do you do? So hard signs go to theater, soft signs you need imaging, and subsequent from imaging you can plan. And this is also for intraoperative management. So what do you see on table and what you decide to do. So depending on how bad the local destruction is. So incomplete transaction, repair, segmental loss, grafts. If there's soft tissue loss that is significant enough, you need muscle cover. Unstable or very, very bad gastrilo 3C injuries, you want to consider a shunt, and later on for definitive management. They actually advocate a completion arteriogram. So after their bypass, they run through a CTA, and depending on that, you may need a redo, or you might need to just come back. So this is something nice to have, especially if you don't do vascular repair very often. So in summary, vascular injuries are time dependent. So you need to know what you're doing for the best chance of the patient actually retaining and salvaging his limb. High degree of suspicion is needed. 3 questions to answer for the initial workup. Is it viable? If it's salvageable, and what level it is at. And for the surgeons who's doing the repair, preoperative planning is important, and on table be OCD and be very fastidious in your clinical techniques. I think that's it.
Okay, thank you, Ms. Tiong, for the very informative talk. I think all the presentation went really well, very informative to all of us who are dealing with vascular trauma in our daily work. All right, we'll take one question that just came in. From Shukri, how about closed fracture with upper limb brachial artery injury? Patient presented late, more than 10 hours, with already sign of skin changes, i.e. mottling or demarcation, and cyanotic changes at fingers and neurology deficit. What are option treatment, attempt repair or amputation? So I'll open it up to the panelists. Mr. Said, would you want to take this question, please?
You're talking about the skin changes or something?
No. He said signs.
Or something? You hear me?
Yeah, so basically what is question is a closed fracture with upper limb brachial artery injury. Patient presented late more than 10 hours with already signs of skin changes, i.e. mottling or demarcation, and cyanotic changes at fingers and neurological deficit. What are the options of treatment? Attempt repair or amputation? It's in the chat box. Mr. Said?
I think, Faisal here, I think we need to treat patient as general, as a whole. If you deal with this condition, this patient is young patient, good premorbid, and CK level just hundreds only, we can give a try to salvage. Because upper limb, you know that quite precise limb, and the tendency to sustain ischemia longer than lower limb. I don't know what you mean by neurological deficit. Is totally paralyzed or is just sensory loss? Yeah. So that's my management. But in case it occur in elderly with CK over 1,000, 10,000, 20,000, and you can see clear cut the demarcation, then the only option the amputation. Even we revise also, we can one patient that possibility in amputate. But upper limb, we try to save the limb as much as possible.
Any other thoughts? Mr. Yuzaidi, Mr. Azuddin, any thoughts?
Hello.
Yeah.
Basically, from the description, is a Rutherford 3, but as Mr. Faisal say, it's upper limb. So what you can do, you can just do a fascectomy of upper limb first, and see the muscle. If the muscle is already dead, then it's a amputation. But if the muscle is still viable, you can still attempt for revascularization.
Okay, thank you, Mr. Azuddin. Another question: for the case as a birth, where bleeding is secured with single level transection of the brachial artery, stable clinically, transportation takes 5 hours, will heparin be useful to bridge through the journey? Any thoughts from the panelists?
So brachial artery already transected, right?
Yeah.
So me patient is bleeding. So starting heparin can cause, makes the condition become worse.
Okay. All right. And the last question: how long you would put patient on antiplatelet following arterial repair? Is there any difference in terms of duration between graft versus primary repair? Any one of the panelists?
There's no standard cut point duration, but what being practiced, basically once you put patient on graft, over inactive or synthetic, it advised to start patient on antiplatelet. Depend. I prefer 3 to 6 months is adequate, unless patient have signs of ischemia. But primary repair is a quite big vessel like axillary artery, maybe just temporary. But the smaller the vessel, the need of antiplatelets is there. Majority we try to start antiplatelet also because the morbidity related to antiplatelet is minimum. So it's no lose for us to start antiplatelet.
Okay.
Yeah, I also agree with Faizul. Most of the time when we do big vessel repair, we just give the patient a short course of antiplatelet therapy, especially if you use an graft. We don't use it for prolonged usage. But I do agree. I do notice some people don't give antiplatelet therapy, especially for the young. But it's like 50-50. I mean, some agree, some don't. You know? But for smaller vessel, I prefer longer duration, but usually not more than 2 months.
I think the only available consensus regarding the use of antiplatelet in the native graft is the cabbage, how long, but actually it is, those are actually having the premorbid diabetic, hyperlipidemia, they are all with premorbid. But I think most of the trauma patient, vascular trauma patient, majority are young, they are no premorbid. So I think 3 to 6 months just to prevent any thrombosis, I think just would be fair.
Okay.
Very short course, I mean, not for prolonged usage. For trauma patient, they're doing very well.
Yeah, true.
Without any antiplatelet therapy.
Okay. So in terms of time constraints, first and foremost, I'd like to thank all the speakers and the panelists for keeping yourself free for this 6th edition of the webinar of the Trauma Surgery Society of Malaysia. However, I have a couple of housekeeping messages. If there is any questions from the participants, you can actually email to the Trauma Surgery Society of Malaysia via their email, which is trauma_surgmalaysia@yahoo.com. And the team would be more than happy to answer any of your doubts. And we also will put up all the presentation on the Trauma Surgery Malaysia website. And for those who have not joined us, those medical officers who are part of the surgery department or any of the surgeons, please join us as we embark on our journey to be part of the chapter in College of Surgeons Malaysia. Without much without much delay, I would then call this an end. Thank you very much and have a good night.
Thank you.
Thank you.
Thank you.